Hey there, welcome to GrowMed. Welcome back to another session of discussing the important topics for the upcoming Fmge, that is the July 2024. So this is a series in which we will be discussing high yield topics from each subject so that these videos will help you in your last minute revision. Already I have uploaded videos on the anatomy and the forensic medicine. So today is the third day in which we will be discussing about the ophthalmology. So do watch those videos also to boost your preparation. So starting the video, blowout fracture, very important topic and asked multiple time in the past years. So this is a repeat topic as well. So what we can see in this blowout fracture is that there will be fracture of the orbit floor of the orbit, fracture of the floor of the orbit, and we can see a classical triad in it, which is important because questions are asked on this triad. The triad is the of in ophthalmos, diplopia and infraorbital anesthesia. So there will be these three things seen whenever there is blowout fracture, and these will be described in a case. So look at the case, read it carefully and try to solve the clinical case. Then the CT, on CT we can see a teardrop sign. So this one is the teardrop sign seen, and on X-ray also we can see the similar sign, but it's not much visible on the X-ray. It is more clearly visible on the CT, and this one is the CT. So this image based question can also be asked. So simple one image, they can give this image and they will ask that this sign, they'll mark this and they'll ask that this sign is seen in which of the following, or they'll give a clinical case describing all these things. They will also give an image and they will ask what is the diagnosis. Then the treatment mostly resolves by itself, so only the conservative treatment we need to do. And if surgery we will be doing if in ophthalmos is present for more than 2 mm and entrapment of the extraocular muscles, mostly in the pediatric patient. Then this was all about the blowout fracture, which you must know. Then visual field defects, a must do topic. So if you analyze the papers of the Fmge, so you can find in all the papers there will be one question on this visual field defects. So either a clinical case, clinical नहीं, either a image based question. तो image based बहुत ज़्यादा important है because they will give this image, similar image, not the same, similar image, and they will mark any of the structure and they will ask that there is injury to this structure. So which of the following defect can be seen? So let's look at them. So this one is the image. So print this image in your brain, and whenever this image comes, without thinking, you need to recall this image and mark the answer. So see, in this image they have marked the structures, like this one is the A, B, C, D, E, F, G, and whenever there is injury to this particular area, we can see a kind of a visual field defect. So if there is um, damage to the structure A, which is the retina. So if there is damage to the retina, then what we can see is the central scotoma, like this. In the central there will be a black spot present, which is called as the central scotoma. Then monoocular vision loss if there is injury to the optic nerve. So which side optic nerve will be involved, that side the vision loss will be seen. Like if it is right side, so as you can see here, the right eye is involved. And this one is the ipsilateral lesion, simple to remember, ipsilateral lesion of the optic nerve. Then optic chiasma. So optic chiasma, very important, repeat topic, asked multiple times, and we can see here bitemporal hemianopia. So this one is the image which we can see in bitemporal hemianopia. So both the temporal visions are lost. So as you can see here, the temporal vision, so these are the nasal visions and these are preserved, but the temporal lesions, these are lost in case of optic chiasma. And most common cause of this lesion can be pituitary tumor, pituitary adenoma. Then moving on to the D. So D is the optic tract, and lesion in the optic tract will cause contralateral homonymous hemianopia. And in this contralateral homonymous hemianopia, the same side is involved, as you can see here. Okay, then moving on to the structure E and the structure J. So these structures, no need to remember this structure, the G, J, I, K, no need to remember these things. Just you need to remember 1, 2, then the third one 3, this one 4, this one 5, and then the sixth one. Okay, so if E is involved, that is the lateral geniculate nucleus, and if this is involved, then we can see the lesion as contralateral superior sector anopia. And then as you can see here, those superior quadrants are involved and there is loss of vision. This appearance is also called as an pie in a sky appearance, this structure, this image. Okay, then moving on to the F, if the lesion is present in the optic radiations, you can see contralateral inferior quadrant anopia called as an pie in a floor appearance, this one image. So the uh, inferior quadrants will be involved and the lesion will be the contralateral. Then moving on to another very important lesion, that is the contralateral homonymous hemianopia with macular sparing. If there is lesion to the posterior part of the brain where there the visual center is located. So this is the important things which you must know from the visual field defects. The two main are this bitemporal hemianopia and this macular sparing. Then moving on to retinoblastoma. So retinoblastoma is also a repeat topic and frequently questions are asked on this. So gene involved is the RB1 gene, asked in relation with the patho, also present on the chromosome 13q14. Important. Then clinical features are the leukorrhea. So as you can see here, that a whitish appearance of the eye. Then loss of vision can occur, inflammation, uveitis, and intraocular calcification. So this appearance, this leukorrhea, is mostly due to the intraocular calcification, and this is an important feature seen with this retinoblastoma. And questions one-liners have been asked that a most common cause of intraocular calcification is retinoblastoma. Investigation of choice is the MRI, and on biopsy we can see the Flexner Winter Steiner rosettes. So these are the Flexner Winter rosettes, and you can see here that well defined lumen. So this lumen is visible, well defined, and it is surrounded by various cells. So important image asked in relation with the patho also. So they can give the image based question also. They'll give these two images and they'll describe the features like leukorrhea, loss of vision, inflammation, and uveitis, and what is the diagnosis. So you need to choose it as the retinoblastoma. Or they can also ask they can give the diagnosis as it is a retinoblastoma, and this condition is caused due to mutation in which of the following genes. So it will be the RB1 gene. Then treatment is the laser photocoagulation. Then chemotherapy, we will be using VEC, vincristine, etoposide, and cyclophosphamide. So these are the chemotherapeutic agents we will be using. And if more than 50% is involved, then we need to go with the enucleation. And another important one-liner asked is most common site of metastasis, optic nerve. So these were the things which you must remember from the retinoblastoma, a very important topic must do. Then moving on to the keratitis. So keratitis also is an important topic and frequently questions are asked on the type of the keratitis. The causative organisms. So these are all the causative organisms. So bacterial Pseudomonas is the most common, then second most common Staph aureus. Viral will be the HSV1. Aspergillus, for the fungal keratitis, it will be Aspergillus most common. Then second most common is the filamentous fungi. Then acanthamoeba with the protozoa. Famous question, very very famous question associated with the contact lens wear. So whenever you see this, so this one is a very famous question, the contact lens wear. So whenever you see this contact lens wear and the acanthamoeba, uh, whenever you see this contact lens were given in the question and in the options, if at all there is this protozoa or the acanthamoeba, then mark the answer as the acanthamoeba, because this one is the favorite questions of the FMG and also a repeat topic. Then ring shaped ulcer is seen in this protozoa and treatment is by the PHMB. So these are the images, important images which you must know. So as you can see here, the hypopyon corneal ulcer is seen in case of the bacterial. So hypopyon corneal ulcer. Then moving on to this another very important image, dendritic ulcer. So the ulcer is seen in shape of the dendrite. That's why it is called as the dendritic ulcer, seen with the viral, and treatment a cyclovir. Fungal finger-like projection, as you can see here, the feathery margin. This is also called as the satellite lesion seen with the fungal. Then protozoa ring-shaped ulcer. So this you can see that the ulcer is forming a shape of a ring. So very important topic. Also, I have uploaded a detailed video on this keratitis. So now I have just revised it quickly so that we will be finishing a lot of topics in a less time. Then moving on to the congenital nasolacrimal duct blockage, which is also called as the congenital dacrocystitis. So what happens in this condition is there is persistent wall of Hentzner, due to which there will be discharge coming out, and also epiphora. Epiphora means the watering of the eyes. So let me explain it to you in short that what exactly happens in this. So this one is the lacrimal sac, and from here the lacrimal sac drains into the nose. So this one is the nose, and what all tears or what all secretions are produced in the eyes, these are drained into the nasolacrimal duct. But what happens in this condition is due to the persistent valve, the secretions, they do not go into the nose, so they flow back into the eyes, causing epiphora. So this one is the basic pathology behind this congenital nasolacrimal duct blockage. Then clinical features are the epiphora unilateral. It is mostly unilateral and painful condition. Then treatment, we will be doing the Krigler hydrostatic sac massage. So questions are asked mainly on this treatment of the nasolacrimal duct block, because this treatment is classified based on the years in which year the patient belongs. Like for example, the child is 5 years, then which treatment you will be doing, or they can ask the child is 1 year, which treatment you will be doing. So let's look at those points. This sac massage we will be doing if the patient is or the child is less than 6 months, and syringing and probing done if more than 6 months or 1 year. More than 6 months till 1 year we will be doing the syringing and probing. And DCR dacrocystorhinostomy, this one is done when more than 3 years and opening is made into the middle meatus, so that this water whichever is coming from the eye, so that it easily drains into the nose. And then question in the last Fmge, the question was asked that bones removed in the DCR. So it is the lacrimal frontal process of the maxillary and the nasal bone. So these bones are removed in this surgery, and you need to remember these years, in which year we will be doing which treatment. And this one is the image of the instrument used for the DCR. So questions are asked giving this image, that this image is used for which of the following condition or which of the following surgery we will be using this image. Okay, so these were the points which you must remember from this nasolacrimal duct blocking. Then moving on to the trachoma. Trachoma also a very important topic. So this one is the most common infectious cause of the blindness, and causative organism Chlamydia trachomatis ABC. Then the important features of this trachoma are the sago-green follicle. As you can see here in this image, there are follicles present which appear like a sago grain. So that's why it is called as a sago-green follicle appearance. Then we can see Herbert's pit present at the limbus. These pits which you can appreciate here, these are called as the Herbert's pit, and these are present at the limbus. So the normal anatomy of the eye, so the limbus is the location which is connecting the cornea and the sclera. So at that location we can see this Herbert's pit. Then Art's line present on the upper palpebral conjunctivitis. So conjunctiva, and this image, this line, as you can see here, this line is called as the Earth's line. Then this line causes scarring of the conjunctiva. Moving on to the classification, which you must remember, Fisto classification. What does the Fisto stands for? F for the follicular inflammation, then I for the intense inflammation, S for the scarring of the eye, then T for the trichiasis, and O for the corneal opacity. Then treatment, we will be using the azithromycin 1 mg oral 1 dose, and this one is the main treatment option. So if at all a person is allergic to this azithromycin, we can also use the doxycycline. So it is a second line drug if at all azithromycin is not working or the patient is allergic to it. Another important strategy for this is the SAFE strategy. So S stands for the surgery, A stands for the antibiotics, F facial cleanliness, and E for the environment cleanliness. So this one is the full form of the SAFE strategy. Then moving on to important topic next, amblyopia or the lazy eye. So what we can see in this amblyopia is blurred vision, double vision and squint. So this is most commonly seen in the children of age 10 to 8 to 10 years. Between this age we can see this amblyopia. So crowding phenomenon is seen in this. So this was a PYQ, and treatment is the occlusion therapy, or we can also do penalization. Penalization means the muscle weakening by the atropine. So we will be giving the atropine in the eye which is not affected. So this is the eye, so it will be unilateral. One eye will be affected in the amblyopia, and what happens is that one eye will not be working properly. There is no injury to the eye, or there is no anatomical cause present or any physiological cause. It is just that the eye is not working properly, due to which what we will do is we will occlude this normal eye and allow the person to stay or to do the work using this lazy eye, so that we are stimulating this lazy eye to work. And the same for the penalization. So we will be giving a tropin in this eye which is normal, and then we will be making this eye also weak, so that this eye will start working. So this was about the amblyopia. So the buzzwords present, or the hint which would be given in the question: crowding phenomenon, then lazy eye, and 8 to 10 years of the age, and treatment occlusion therapy. Then diabetic retinopathy, also a repeat topic. Questions are asked one-liners on the hallmark feature, which is the neovascularization. The earliest feature is formation of the microaneurysms, and most common cause of loss of vision is the macular edema. So see, these questions can also be asked in integration with the case. तो पूरी की पूरी diabetic की वो case describe कर देंगे, that a patient, diabetic patient comes to the OPD with so and so features. So on examination you see you find this and this. So what is the most common cause of the loss of vision? मतलब कि पूरा का पूरा एक 5-6 लाइन का बड़ा सा केस डिस्क्राइब कर देंगे, और लास्ट की जो लाइन रहेगी ना, देयर विल बी द एग्जैक्ट क्वेश्चन द एग्जामिनर वांट टू आस्क यू. तो यहाँ पर पहले लास्ट की लाइन में पढ़ना कि व्हाट द एग्जामिनर इज आस्किंग, एंड देन ट्राई टू रीड द होल केस लेटर. क्योंकि अगर वो ऐसे पूछ रहा है कि मोस्ट कॉमन कॉज ऑफ लॉस ऑफ विजन इन डायबिटिक रेटिनोपैथी, तो फिर तो ये पूरा पढ़ना वेस्ट हो गया ना. इट इज़ अ वेस्ट ऑफ टाइम रीडिंग द होल 4-5 लाइन्स ऑफ द एक्सप्लेनेशन which they have given. And these are mostly the tricks to so that students will waste their time, and फिर वो घबरा जाएंगे, then they'll panic कि इतना बड़ा क्वेश्चन है ऐसे करके. So don't fall for all these things. Try to answer smartly in the exam hall. Read the last question first, and that you need to practice from now only. So whenever you're solving the MCQs, try to read the last. If at all the question is 4 or 5 lines, then first read the last line. Because if you practice this from now only, then only you can incorporate it in the exam. If you don't practice it, तो directly exam में तो ये आएगा नहीं, मतलब तुरंत दिमाग फ्लैश नहीं होगा, because exam hall में already there are a lot of things going on in the head. So let's talk about the diabetic retinopathy. So these are some important one-liners. Then screening. A very important questions asked from the screening. So in case of type 1 diabetes mellitus, we need to do screening after the 5 years of diagnosis, because these the complications here, these micro complications, these take time to appear. Suddenly तो ये appear नहीं होंगे. तो type 1 में they will need at least 5 to 6 years. इसीलिए we will be doing screening at after the 5 years of diagnosis. But in type 2 we need to do the diagnosis immediately, because we do not know ना diabetes जो टाइप 2 है, टाइप 2 कब स्टार्ट हुआ, कितने दिनों से हो रहा है पेशेंट को, वी डू नॉट हैव दैट आइडिया. तो इसीलिए at the time of the diagnosis we need to do the screening for the diabetic retinopathy. Then two types diabetic retinopathy: proliferative and non-proliferative. So the features of the proliferative: new blood vessels formation is seen, which is the hallmark feature. Then loss of vision is due to the neovascular glaucoma, PYQ. Then vitreous hemorrhage, tractional retinal detachment are also other causes of loss of vision. And the question was asked in the past year that which kind of retinal detachment is seen in case of a diabetic retinopathy. So the answer was the tractional. So retinal detachment, there are of three types. So rigmatus degeneration, then tractional and another one type. तो इसके एग्जांपल्स आपको देखने पड़ेंगे कि कौन सी डिसीज में कौन से टाइप की दिखेगी. Then non-proliferative microaneurysms seen, then dot and blot hemorrhages, soft exudates. Loss of vision is due to the macular edema, and treatment laser photocoagulation and anti-VEGF drugs. Then treatment pan-retinal photocoagulation except the macula for the proliferative. So these were the important things which you must remember from the diabetic retinopathy. Moving on to the anti-glaucoma drugs. So quickly I will be discussing about these drugs, and already I have uploaded a complete video on the drugs which are used in the ophthalmology. So do watch that video as well, in which all the important drugs have been described. So in glaucoma, what happens is the intraocular pressure is increased. So the treatment is to reduce the intraocular pressure. Done by two methods: decrease the production or increase the outflow. Decrease production done by the alpha agonist and the beta blocker. Alpraclonidine and the bromonidine, these are the drugs used, and these are the particular side effects. Then timolol side effect is the asthma and asked multiple times. So this one is a PYQ. Then increasing the outflow, we will be using pilocarpine, physostigmine, lantanoprost, and the particular side effects which are seen by these drugs. Then drug of choice, these are the various one-liners asked in relation with these glaucoma drugs. So in children, we will be using dorzolamide, which is a safer alternative. Then for acute angle, mannitol. Open angle, it is the lantanoprost, and fastest acting are the mannitol and the acetazolamide. Then moving on to the cataract. So cataract image based questions are asked mainly. So they can give simple one image and they will ask that this cataract is seen in which of the following diseases. So you need to mug up this cataract. मतलब cataract जैसे ही हम बोले तो सारी cataract की images आपके दिमाग में आनी चाहिए. You need to कि सारी किस चीज़ में किस टाइप की दिखती है. So in myotonic dystrophy, we can see this cataract which is called as the Xmas tree cataract. Then snowflake cataract seen in the diabetes mellitus. Wilson's disease, copper deposition. This one is due to the copper deposition, and sunflower cataract is seen in this disease. Oil drop cataract seen in the galactosemia, and this one is the only cataract which is reversible. So this one is also asked. ये आपको पता होना चाहिए. This important thing. Then in trauma, we can see the rosette cataract asked as a multiple times. So this one is a favorite PYQ. तो rosette cataract का image दे देंगे and they'll ask that this cataract is seen in which of the following, या फिर वो दे देंगे कि a patient presents had a trauma to the eye and present to the OPD. The image is given what type of cataract it is, the rosette cataract. Another important thing seen in the trauma is the vicious ring. तो ये vicious ring क्यों होता है? It one is due to the bleeding. तो यहाँ पर आप देख सकते हैं bleeding vessels जो है blood vessels, they bleed due to the trauma and they form this vicious ring. Then hypermature cataract, so also called as the Morgagni cataract, and you can see this image in it. And coralliform, also called as the congenital, so you can see this appearance in it. So coralliform cataract seen with the congenital. Then another two important things, most common cause of the blindness in the world. So cataract is the most common cause of the blindness in the world, and based on the morphology it is divided into three types: nuclear, cortical and posterior subcapsular, based on the location कि cataract कहाँ present है. So see, this one is the lens, and lens की जो middle part है that one is the nucleus, and this one is the cortical part. तो अगर वो cataract यहाँ पर हो रहा है then that will be the nuclear, and cortex पे हो रहा है तो cortical, and posterior subcapsular तो posterior part में होगा. And जो ये nuclear है, this will be causing the index myopia and the second sight, and this cortical, also known as the cuneiform or wedge shaped, and it causes nyctalopia. Posterior subcapsular, this is caused by various drugs like the steroids. Then radiation also causes posterior subcapsular cataract and complicated cataract. So these are the important points which you must remember from the cataract and the images also. So this was a quick review of the important topics from the ophthalmology. So you can expect at least 4 or 5 questions in the exam. And if we are lucky enough, then mostly all of the questions can come in the exam. So all the best for the FMGE. If you're new to GrowMed, subscribe to GrowMed and join me on the Telegram to make this preparation more funful and easier. Thank you so much for watching this video, guys. Bye bye.